Hello, and thank you for joining us. My name is Jan Johnston. This presentation addresses wrong site surgery, its definition, the scope, risk factors, as well as factors involved in its prevention. This presentation is based on an article published in the June 2007 Patient Safety Advisory. It is available on the website of the Pennsylvania Patient Safety Authority, which is responsible for the Pennsylvania Patient Safety Reporting System, or PASERS. Wrong site surgery involves all surgical procedures performed on a wrong side, wrong body part, wrong procedure, wrong patient, as well as the wrong site or level of a correctly identified anatomic site. The Joint Commission requires that wrong site surgery be reported as a sentinel event. The National Quality Forum has listed wrong site surgery as one of its serious reportable events, known as never events, and its elimination is one of the major goals of the World Health Organization's Alliance for Patient Safety. The penalties for wrong site surgery can be high. For example, in New York, a choreographer recently was awarded nearly $500,000 for surgery on the wrong knee. In Wyoming, a patient recently was awarded over $1 million for surgery on the wrong disc space. In Florida, surgeons are fined an average of $10,000 and as much as $20,000 when a wrong site surgery occurs. Yet this has had little effect on the incidence of wrong site surgery in that state. A Harvard study of wrong site surgery claims and lawsuits in a database of a large medical malpractice insurer estimated the incidence of wrong site surgery to be once in about every 100,000 surgical procedures, and that a risk manager at a hospital would see only one wrong site surgery lawsuit every 5 to 10 years. However, New York's reporting system, NIPORTS, receives one wrong site surgery report for every 15,000 operations. The American Academy of Orthopedic Surgeons, or the AAOS, estimates that 1 in 4 of their surgeons will experience a wrong site surgery at least once during their career. To solve the problem, the AAOS proposed marking the surgical site. Many organizations, including the Association of Perioperative Registered Nurses, or the AORN, encourage preoperative site verification involving the patient. The American College of Surgeons, or ACS, among other professional organizations, encourages the use of a preoperative timeout or surgical pause. In 2003, these three components were adopted by the Joint Commission as the Universal Protocol for Preventing Wrong Site, Wrong Procedure, and Wrong Person Surgery, or the Universal Protocol. More than 50 professional associations and organizations have endorsed the Universal Protocol. However, the protocol has had little overall impact on the problem, as apparent in wrong site surgery reports submitted to PASERS. There has been no reduction in the frequency of these reports since 2004. Of these reports, 174 reached the patient. In the first 2.5 years of reporting, PASERS received 427 serious events and incidents about wrong site surgery, about 1 every 2 days. These reports were submitted from 129 of 379 facilities, or about 1 in 3. Of interest for wrong site incisions made, 18 facilities had more than one such occurrence in a 12-month period. Most reported occurrences, however, did not reach the patient. For every 5 reports, 3 did not touch the patient, but another 2 involved at least starting an invasive procedure, and one of those was a complete wrong site procedure. Over 2/3 of the wrong site occurrences involved the wrong side. The extent of the error differed by type. Wrong side and wrong patient errors were more likely to be caught early, but wrong procedure and wrong body part errors especially spinal surgery involving intraoperative radiologic confirmation, were more likely to proceed to completion before the error was discovered. Wrong site surgery most commonly involves symmetrical structures followed by the spine. Pazers has also received unusual wrong side errors, 3 involving the colon. In one case, a right hemicolectomy was performed for a lesion, but postoperative follow-up revealed that the originally diagnosed lesion remained in the sigmoid colon. Another report involved difficulties identifying the abnormal twin for selective abortion. Pazers evaluated contributing factors of wrong site surgery errors that resulted in patient contact. The behavior of the surgeons in the OR was most commonly identified, such as specifying the wrong surgical site. Timeouts either not being performed or performed improperly was the second most commonly identified factor. In some cases, wrong site surgery was not prevented, even with a timeout performed without apparent problems. The activities of the anesthesia provider were mentioned in 17% of these reports, primarily involving blocking the wrong site prior to the timeout. Next were failures to properly verify the site with consents and other documents. 11% of the reports indicated that improper patient positioning or prepping contributed to the wrong site surgery report. Because Pazers receives near-miss reports, factors contributing to successful recovery without patient contact were identified. The most common factor mentioned was information provided by the patient or family, followed by involvement of the surgeon in the initial reconciliation and verification before the patient entered the OR. This was followed by verification using the consent and other patient information, including the surgeon's office records and the preoperative nurse performing the initial reconciliation. When the number of times a factor contributed to wrong site surgery patient contact is subtracted from the number of times these factors contributed to a recovery from a potential wrong site surgery without patient contact, the above factors were strongly associated with wrong site surgery prevention. Of the factors producing a net negative effect, the greatest single source of wrong site surgery error involves scheduling information from the surgeon's office, but only 5 of these reports resulted in patient contact. As you recall from the previous slide, activities of surgeons in the OR were commonly mentioned as contributing factors in wrong site surgery reports. However, activities of surgeons in preoperative site verification procedures were strongly associated with wrong site surgery prevention. Many conclusions can be drawn from this analysis. The following actions in isolation do not always prevent wrong site surgery: asking the patient or surgeon, marking the patient's surgical site, or performing a timeout. A single timeout just before the incision is a flawed strategy that violates safety principles of redundant checks of operator-dependent critical steps and ignores the potential impact of confirmation bias. Confirmation bias involves erroneously processing observations based on pre-existing beliefs. Confirmation bias is evident in this wrong site surgery report submitted to Pazers. A patient was admitted for left knee surgery. The patient was properly identified, the site properly marked, and the patient was brought to the OR. The physician elevated the patient's right leg for the procedure. The nurse prepped and draped the patient. During the timeout, no one recognized that the wrong leg had been prepared. The procedure was performed on the incorrect leg. Because the surgeon inadvertently lifted the wrong leg for the prep, the surgical team assumed it was the correct leg. Simply marking the surgical site will not prevent wrong site surgery. Site verification is a complex process involving the nurse, patient, the surgeon, and the anesthesia provider, an accurate OR schedule and consent, and a review of all the patient information before any care is given. This is a process that has not been fully recognized in the past. Preoperative verification is an important step in the complex process preventing wrong site surgery. This report submitted to PASERS is an example of such a save. The patient was in the holding area. The permit and scheduled procedure indicated the left side. The patient, however, stated the right side was to be done. The physician reviewed all paperwork, doctor's notes, and the current X-ray, spoke with the patient, and confirmed that the right side was the correct side. Then the surgery proceeded. The PASERS experience to date reveals that wrong site surgery that touches the patient is expected to occur once a year in the operating room of a 300-bed hospital. Focusing on a single process component such as surgical site marking or the timeout, rather than considering wrong site surgery prevention processes as a whole, cannot prevent wrong site surgery. Patients have a right to expect that wrong site surgery will not occur, and this must be the goal for Pennsylvania healthcare facilities as well. Thank you for joining us for this presentation. We hope you'll find this information useful in your own facility. This presentation was developed as part of the Pennsylvania Patient Safety Reporting System. To learn more about PASERS and to find more information on this and other topics, visit the Patient Safety Authority website at www.psa.state.pa.us. For further details on any of the topics discussed during this presentation, refer to the source article from the June 2007 Patient Safety Advisory.